My first patient today is a wound patient. I read the referrals from the doctor last night. I will go in and assess the patient and then speak with the family and the physician to decide a plan of care. I'll decide how frequently the patient's being seen, what supplies they need. We are often the eyes and ears for the physicians and can give recommendations for what the wound care should be. We teach the patient how to manage their medicines, and perhaps if the patient needs med changes, we can make those with the physician. Depending on how the patient's wound progresses, we may need to add some visits. We may need to extend the frequency. If the patient is having concerns at home with safety or weakness, things that would cause the wound not to heal as quickly, we may need to order physical therapy, occupational therapy. I would coordinate with the family and the physician to get these orders. One of the things I like about case management is that we can get the things the patient needs. We're able to see what the patient is missing in the home to keep them in the home instead of back in the hospital. I had a heart failure patient that I had the opportunity to watch go through all of the phases of heart failure. He started out on a milrinone drip where I took care of his IV and taught him signs and symptoms of infection and how to manage his disease. He then went on to get an LVAD, and I took care of his LVAD dressing and helped coordinate with the LVAD team. And then as his disease process progressed, I actually got to see him get a heart transplant and progress and watch his wound heal. And I had the opportunity to see him walking down the street. Just happened to see him a few months later as if nothing happened. He was in perfect health. And it was wonderful to be able to see that spectrum of care, see him start out so sick and see that my care helped impact him and gave him back his quality of life.